Hello, I'm Duggan. I'm Clinical Director of Healthcare Variation at the Australian Commission on Safety and Quality in Healthcare. This is the second in a two-part series introducing you to healthcare variation and to atlases. In the first of our series, we discussed variation, the difference between warranted and unwarranted variation, and why it's so important to identify unwarranted variation so that we can drive more appropriate care. In this, the second of our series, I'm going to look at the Australian Atlas and atlases of healthcare variation and discuss some of the findings we've had, some of the surprises we've had, but also some of the great work that we've been able to do and clinicians and health system managers and consumers have been able to drive as a product of the data that the atlases have revealed about some very important areas of healthcare provision. Let's start. One of the most surprising experiences I had, the atlases. I don't know whether it was a surprise to you, but it was certainly a surprise to me to find that Australia has one of the highest rates of hysterectomy among countries belonging to what's called the Organisation for Economic Cooperation and Development, the OECD. It was a surprise to me because hysterectomy used to be the only treatment available for heavy menstrual bleeding. But those days have gone. We've developed the oral contraceptive pill, we've developed the intrauterine device. Clever surgeons have even developed minimally invasive surgery to remove the lining of the uterus, which is the source of bleeding, without needing to have the major surgery of removing the uterus. When we ask clinicians why it might be that Australia, despite its sophisticated health system, should still have a high rate of hysterectomy, the answer was that it was the tyranny of distance. Women in rural and remote areas would still opt for hysterectomy because it was definitive treatment. They couldn't afford to travel the hundreds of miles with overnight stays for treatments that might not work. They needed the once-only definitive treatment. Seemed plausible? Then we explored the data. To my surprise and the surprise of the experts we consulted, when we looked at the data, mapped the data in the second atlas of healthcare variation, we found that most of the highest rates of hysterectomy were not in remote areas, but in inner regional areas of Victoria. But without an atlas, efforts to increase access to these effective low-risk treatments would have been wrongly targeted. The women in greatest need in these regional areas would not have been informed of more appropriate, less invasive treatment options. Because we wouldn't have considered them to be part of our target area. I find atlas findings recurrently surprising and challenge my preconceptions and misconceptions about healthcare, how healthcare is being delivered in Australia. I find stark differences between regions, by socioeconomic group status that I don't expect, differences between Aboriginal and Torres Strait Islander groups, differences by gender when the diseases being treated aren't different between the genders, and differences by funding status. And again, it raises the question of how consistently we are providing appropriate care. So what do we stand to gain? Well, atlases allow us to get that big picture that we don't see from our isolated perspectives. It means we can address healthcare problems on a bigger scale, target areas of most need, and ensure that more people consistently receive appropriate care. Fewer people will be unnecessarily harmed because they will get the care they need, or they will no longer be receiving interventions that they don't need. And we'll end up with a much more efficient, effective system that benefits all of us. Atlases contribute very much to this review of the data because they clearly demonstrate what's going on. It's that visual image. A picture paints 1,000 words. The Dartmouth group in the US were the first to use atlases. And since then, a number of countries have taken it on as a means to drive healthcare reform. Canada, European countries, Australia, New Zealand. In our Australian atlases, which we started in 2015, we've looked at medications, healthcare interventions and surgical procedures. We've selected the medications that really are critical to get right. In the first Atlas of Healthcare Variation, we looked at antibiotic use. We know that the overuse of antibiotics is leading to antibiotic resistance and increasing difficulties treating infections to the point of not being able to treat. And we know already that our rates are much higher than other countries. So it was important to get that data. We've looked at antipsychotics, again a problem area, opioids and many others. We've looked at healthcare interventions and surgical procedures, such as operations for back surgery, for knee surgery, cataracts, areas where we know that we want to get it right. Now, with our atlases of healthcare variation, we've mapped according to place. So we know what it's like for people living in different parts of Australia. It's not where you receive the care, it's where you live. We've mapped according to statistical area 3s, SA3s. So we divided up the country into those 300 odd SA3s, and that's populations of up to 300,000. So you can imagine the SA3s are quite small in the densely populated metropolitan areas, but quite large in those rural, remote areas. We've gone beyond that to then further analyse the data and categorise regions according to whether they're metropolitan, regional or remote, to see whether there are differences and patterns and consistent differences between the groups. And then with each of those regions, we've allocated the areas within, for example, metropolitan areas into their socioeconomic status, providing a wealth of data. The data we've used is administrative data from the medical benefit scheme, from the pharmaceutical benefit scheme, which supports our medications, from the perinatal data set and from patient admission data. We've looked at insurance status, where the data is available, Aboriginal and Torres Strait Islander heritage. The results have been surprising. We found a 12-fold variation, according to where people live, in hospitalisations for diabetic complications across Australia. It's extraordinary. You would expect some admissions to occur for diabetes, but you'd expect that a highly sophisticated health system would ensure that people were able to manage their diabetes in the community with access to a diabetic educator, a GP, a diabetologist, a podiatrist to look after their feet, someone to look after their eyes, and that admission would be a very uncommon thing. We found 30-fold variations in MBS-funded colonoscopy. That defies what we know about the epidemiology of disease and what we know about the evidence of the appropriate use. We found a 75-fold variation in the dispensing of medications for ADHD, suggesting that there are, when we talk to the experts, two groups of thought about the place of these medications in the management of ADHD. So using Atlas data enables us to explore differences, socioeconomic status, remoteness, in cultural groups, between cultural groups, in insurance status. It enables us to develop some hypotheses as to what may be going on, such as, is there an evidence practice gap? Is there indication creep? Is there a workforce issue? Undersupply in some areas, oversupply in others. And so it allows us to refine actions to really drive down the unwarranted component of that variation. So let's consider in more detail some of the drivers of unwarranted healthcare variation. As I said at the beginning, to our surprise, we found that the high rates of hysterectomy were in regional places like regional Victoria, 6 out of the top 10 from there. So it raises the question, Are women in those areas getting all the information about all the treatment options? And are they getting the access to those treatment options so they can choose what's best for them? Now, we mapped endometrial ablation. That's that minimally invasive surgery I described that removes the lining of the uterus but saves a woman from having to have their uterus removed. We found a 21-fold variation. It really raises the question of whether women have access across the country to that procedure or whether they have to choose the more invasive surgery. Let's think about indication creep, because it's an important issue when we have the availability of many medications and many new technologies, and the possibility that they may be used beyond what the evidence shows about their benefits. In 2012-13, there were 38,500 admissions for tonsillectomy in Australia, and there was a 7-fold difference between the rates in the lowest and the highest areas. Now, we know from data from the UK and US and elsewhere that there has been a consistent decline in tonsillectomy for tonsillitis. But in a number of countries, there's also been a rise in tonsillectomy for obstructive sleep apnea in children. So the important question that we need to ask when we see these rates and we see the 7-fold difference is, what's the evidence base for this indication? How good are the data? Are the studies comparing surgery with watchful waiting? Are we looking at outcomes to know that we are doing good, not harm? What about workforce? Another driver. I said earlier, metropolitan areas have much higher rates of colonoscopies than regional and remote areas. Surprisingly, and contrary to the epidemiology of disease, the rates are highest in the highest socioeconomic groups in metropolitan. Yet we know that the risk factors for bowel cancer are more prevalent in lower socioeconomic groups. So can these rates in metropolitan areas be explained by supply-driven demand? Take, in contrast, diabetes, a 12-fold higher rate of hospitalisation, diabetic complication. They occurred in predominantly remote areas. So is there a lack of those service providers I talked about? Do we have the right mix of providers so that people can manage their diabetes, prevent complications, and not need to be admitted to hospital? So how have the atlases driven change? Well, we've made changes in a number of areas, but let me just talk about a few. The Commission, with clinicians and consumers and health service managers, have developed clinical care standards for a number of conditions where we've seen that there really seems to be a gap between evidence and practice. So we've developed clinical care standards for heavy menstrual bleeding, for management of knee pain, hip fracture, for cataracts, the use of colonoscopy. And what those standards do is just list the 8 or 10 key evidence-based or expert advice-based practices that should occur in the management of these conditions. Those standards are now available very easily on our webpage. I recommend that you review. We've also fed the data from the Atlas back to the Medical Benefits Scheme, and you'll know that we've had a recent MBS review, and that data has informed some of the changes, such as in the MBS item numbers for colonoscopy, for arthroscopy, and for back surgery, all to promote evidence-based practice. We've also informed the national standards. So in the second edition of the national standards, you'll now see the standards which are used to accredit all our hospitals and day surgeries recognised the need for health services to provide the data on healthcare interventions back to clinicians so they can examine the data and look to see if we've got variation going on, and they can explore the data and identify and reduce unwarranted variation. And the Commission has provided a guide which is available on our website to help people do that. Atlas findings have also informed our national workforce strategy and are helping to promote better distribution of our workforce. But let me end by giving you a case example. And let's go back to hysterectomy. As I said earlier, we found we had, compared to other OECD countries, a really high rate of hysterectomy. When we looked at our Atlas data and broke down the data by where people live and mapped it, those SA3s, we found sevenfold difference across Australia, but we found over 6 or 7 of those highest rates were in regional Victoria. And as you can see from the map, when you colour code by volume the SA3s and give the areas with the highest rates, the dark blue, and the areas with the lowest rates back to a yellow, you can see the marked visual difference of lower rates around Melbourne but higher rates in regional areas. And those higher rates were quite impressive. So for Ballarat, for example, the rate was 744 per 100,000, whereas the rate for women having hysterectomies in Melbourne was 119 per 100,000. So what actions occurred as a product of that? Well, the Department of Health and Human Services in Victoria and Safest Care Victoria took the data, drilled down on the data. They got their clinical work group to look at the high rates of hysterectomy, and there was a conclusion drawn that there was unwarranted variation. They collaborated to promote the Commission's heavy menstrual bleeding standard and engaged their local primary health networks to develop pathways that follow the standard and manage heavy menstrual bleeding according to the standard. And they developed clinics such as Well Women's Clinic, which were designed to offer choices in primary care as a circuit breaker for women who might otherwise be on a trajectory straight to surgery. The outcome is already showing promise. In 2014-15, when we mapped hysterectomy, the rate was 281 per 100,000. The rate of hysterectomy in 2018-19 was 236, a 16% fall already. So what next? I'd recommend that you explore your data, strengthen your hypotheses about what's going on, and refine your actions to reduce unwarranted variation. You can contribute to improving healthcare by looking at variation in your practice and benchmarking yourself against best practice, against your colleagues, against registry data, and implement changes to promote appropriate care and disincentivise inappropriate care. Resources are available on our website. I said, the user guide and examples from clinical experts who've done it, who are very happy to share their knowledge and expertise. But in the meantime, can I suggest you stay and join us in a question and answer session. Thank you.